Ready? Only got here at 5:30 to make sure this works. Anyways, all right, we're gonna get started. My name is Millard. I'm one of the PGI 5s here. Can't believe I'm doing great rounds already. But basically tonight I'm going to talk about cleft lip and palate surgery, and also talk about humanitarian missions. And the reason why I'm talking about this is because next year I'll be a facial plastics fellow at Oregon Health and Science University with Dr. Sean Wong, and we do cleft lip and palate surgery there. And so I thought it'd be a good idea to start learning about it now before I get up there and start teaching. So I have no financial disclosures. The outline for tonight, we'll talk about epidemiology, embryology, then do a brief overview of clefts and their repair, and then talk about humanitarian missions. So starting with epidemiology. So cleft lip plus or minus palate occurs in 1 in every 1,000 births in the U.S., which is over 4,200 cases per year. Overall, it's 1 in 700 births worldwide. And the ethnic breakdown in the United States is up there. It's very important to realize that cleft lip plus or minus palate is a separate entity from isolated cleft palate. Isolated cleft palate has an incidence of about half that of cleft lip plus or minus palate, and there's no ethnic predilection in cleft palate. So here is just another schematic. So you see cleft lip plus or minus palate with its occurrence, its ethnicity, and the male to female ratio, which is 2 to 1 in cleft lip with or without palate, but isolated cleft palate is actually 1 to 2. And then within cleft lip plus or minus palate, 80% are unilateral, and left occurs more than right, and 20% are bilateral. So etiology. There's a complex interplay of environmental and genetic factors. On the environmental end, we know that maternal diabetes, maternal alcohol use, as well as phenytoin and valproic acid can be teratogens, thalidomide also. And with alcohol, there's actually some studies coming out now that show that it's binge drinking in the early post-conception weeks that actually have the higher association with clefts. And it's something about having the larger alcohol for amount of time that has a higher association with cleft lip and palate. For genetic factors, there's one gene called IRF6, and it's been associated with Van der Waals syndrome. And actually, in patients that have syndromic cleft palates, this one gene has been found in about 50% of the population. But for most kids with cleft lip and palate, or just isolated cleft palate, it's a mix of both environmental and genetic factors. So there's over 300 syndromes associated with clefting. Cleft palate is usually 50% non-syndromic, 50% syndromic. Cleft lip plus or minus palate is 70% non-syndromic, 30% syndromic. But usually when you see a kid with a cleft lip or cleft palate, they should be worked up for a syndrome until proven otherwise. So you want to search for other malformations. Velocardiofacial syndrome is the most common syndrome associated with cleft palate. The kids have a classic appearance, which is a long face, a square root nose, cardiac malformations. And it's on chromosome 22. And there's a microdeletion. For cleft lip, Van der Waals syndrome is the most common syndrome associated with cleft lip. It's an autosomal dominant with very low penetrance, and the kids can have cleft lip plus or minus palate, and they're known for having these lip pits. So when counseling families about the risk of recurrence, if the parents themselves have cleft lips, if the fetus has one sibling that has cleft lip plus or minus palate, the risk of the fetus having it is 4.4%, cleft palate 2.5%. If it's a parent, 3.2% for cleft lip palate, and isolated cleft palate is 6.8%. And if it's one sibling or one parent, it's about 60% for cleft lip and palate and 15% for cleft palate. So now we'll move on to our favorite topic for medical school in Etiology. The following slides are from the Indiana University Anatomy website. They have an animation that goes through craniofacial development. They also have still photos that you can download, which is what I did. Put it into the talk. It's color coordinated and it's really cool. If anyone's interested, definitely should check it out. So the critical period for craniofacial development is weeks 4 to 10 post-conception. And here, this is around week 6, and everything is color coordinated. So here in turquoise, you have the frontal nasal prominence, and that's formed from mesenchyme. In purple, you have the maxillary prominences, and they're formed from the upper part of pharyngeal arch 1. And in pink, you have the mandibular prominences, which are formed from the lower part of pharyngeal arch 1. This then develops into, again, you still have the frontal nasal prominence, but then you develop in brown the nasal clefts, and that's during the 5th week, and these develop in the lateral edges of the frontal nasal prominence. They then develop a central nasal pit, which will become the nostril. From there in peach, you have the medial nasal prominence or processes, which come from the nasal placode. The lateral aspect of the placode becomes the lateral nasal process. And again, still in purple, you have the maxillary prominences, and then sort of brown is the mandibular prominence. So in the 7th week, you start to see more sort of familiar structures. What you have here, this is still the lateral nasal prominence. Now you have the intermaxillary segment, which is a fusion of the medial nasal prominence. And you still have the maxillary prominences, which are undergoing a lot of growth at this time. So what you can see here, it says, what if they don't fuse? So if the intermaxillary segment and the maxillary prominences do not fuse, and if the medial nasal prominences do not fuse to form the intermaxillary segment, you'll have a median cleft lip. And that's really rare. Basically, it's just a midline cleft. And that's because the intermaxillary segment is going to form the nose and the upper lip. So now you have the fusion of the intermaxillary segment with the maxillary prominence, and this is what forms a cleft lip if they do not fuse. So if you have lack of fusion on this side, you'll have a left unilateral cleft lip. If it's on this side, you'll have a right unilateral cleft lip. Now for the palate. So the maxillary prominences, which we saw before in purple, have little outpouchings here, which become the palatine shelves. So this is the tongue, this is the mandibular prominence, and this is the intermaxillary segment, which has fused in the midline. So once the palatine shelves fuse in the midline, and you have this little outpouching from the intermaxillary segment that fuse, now you have the nasal septum and the palate. Here's a good representation. So basically, the intermaxillary segment, the part of that forms the palate is the primary palate. And the separation between the primary palate and the secondary palate is the incisive foramen. And the secondary palate is here in light purple, and that's formed from the palatine shells. And then this shows the uvula comes from the palatine shells, and if you lack of fusion of the shelves in the midline, then you'll have a cleft palate and a bifid. Alright, so now around week 8, the embryo has more of a human shape. You see the nasal pits have become the nostril, the medial nasal prominences have fused to form the intermaxillary segment. The lateral nasal processes are forming the ala and the sidewall. The maxillary prominences have really had a growth spurt and now are larger than the mandibular prominences. And now if everything is fused, you will have a complete palate and normal upper lip. Alright. On to overview of clefts and repair. So for cleft lip, there's basically 3 different ways to look at it. You can have unilateral versus bilateral. You can have a complete versus incomplete, you can have a mesoform cleft lip. For the cleft palate, it's unilateral versus bilateral, complete versus incomplete, primary versus secondary, and a subbeat is cleft. We talked about primary versus secondary, so primary is basically the alveolar ridge is the primary palate. Secondary is the majority of the hard palate and soft palate. Complete versus incomplete. Incomplete would mean if maybe a child just had a hole in their hard palate. And unilateral versus bilateral means if someone has a bilateral cleft palate, then there's usually, when they have the bilateral lip, you can see the cleft through the lip, through the alveolar ridge, and on each side of the palate, and then the whole central aspect of the palate is cleft, so you can see the septum through the palate. Right. So this is our classic unilateral cleft lip with nasal deformity on the left. And so as you can see here, the cleft is the entire vertical height of the lip. You can see here that in the schematic, the patient has a cleft running through the alveolus. You can assume that they also have a cleft palate. What's important to note is the deformity of the nostril associated with the cleft. So this is usually tested on boards, but the ala on the cleft side is usually has a horizontal aperture, which is actually stenotic. The ala itself is displaced laterally and posterior. And as you can see here, the columella is deflected towards the non-cleft side, and so is the caudal septum. So the way I try to remember that is, in order to pull the columella and the septum into the midline, you need to have the complete muscle fibers to help sort of pull it into the midline. And so when you have a cleft, those muscle fibers are incomplete. So everything is being pulled toward the side that has the complete muscle fibers. So the caudal septum and the columella will go towards the non-cleft side. The picture on the right is of an incomplete cleft lip, and depending on how high the cleft is, the patient could actually just have a small area of muscular diaphysis, and there can be some areas where the orbicularis oris is actually completely intact. But all incomplete cleft lips have basically just means that the entire vertical lip is not cleft. Alright, so I'm going to focus mostly on unilateral cleft lip and palate, but in bilateral complete cleft lip, what you see here is that you have the prolabium, which came from the fusion of the medial nasal prominences to form the intermaxillary segment. And the major thing to remember is that you can see here, the muscle fibers of the orbicularis oris do not cross over to the prolabium. On both sides, they insert on the alar base. So this prolabium is completely devoid of muscle fibers, which means that your repair will fail if you just try to suture the muscle to the prolabium on either side. You need to actually make a complete drain of muscle. So here's a schematic of cleft palate. Again, the typical complete cleft lip, alveolus, and palate. And then here is an isolated cleft palate. So the tongue is here by the uvula. So when to repair? For cleft lip, it's pretty established that cleft lip and primary rhinoplasty predicated on the fact that any other syndromes or problems that the baby has is stable, that they are healthy enough to undergo surgery. Most people like to remember the rule of 10, which means that the baby should weigh at least 10 pounds, have a hemoglobin of at least 10 grams, a white count less than 10, and age more than 10 weeks. Now, cleft palate is a little bit more controversial. Some people like to do cleft palate single stage at age 1, and other people like to do a 2-stage approach. And really, what everyone's trying to do is a balance the benefits of doing cleft palate repair for speech, but without hindering facial skeletal growth. So the theory is that when you elevate the mucosa off of the hard palate to make your flaps to repair the cleft palate, when that new mucosa grows in, it has a scar associated with it, and that scar prevents new bone from being deposited And you need the osteoblast and osteoclast working together to have maxillary growth. So for kids who have their cleft palate repaired earlier, they'll have better speech, but they usually have maxillary hypoplasia, so they have sort of a flat appearance to their face. So if you wait until they're older to repair their cleft palate, then their facial skeletal growth will be more normal, but their speech will not improve as much.
Is there good empirical data that shows that? Or is it just what people think?
No, there's been studies that show that if you repair someone earlier, they'll have pretty much normal speech. But if you wait until later, their face has stopped growing, or their face, the proportion between their maxilla and their mandible is close enough that we can't really tell that they have maxillary hypoplasia, but the benefits they get from speech, from having a repair for speech as well. The theory about the scarring and that's I think theoretical. We need to show that. So some people are arguing repair the soft palate, but leave the hard palate and the alveolus open and repair that later in life once the facial skeleton has kind of solidified, because that's not affecting speech and they don't have the maxillary hypoplasia. So that's some of the argument for the two-stage approach. So this slide is not meant for you to actually read it. I can barely read it, but I just want to show that this is Mount Sinai's cleft plan, and it's important to know that when you meet with a family to discuss their child's diagnosis of cleft lip and palate or isolated cleft palate, it's not just a one-time surgery and then you're done. This is basically from birth until teenage years, a series of surgeries, evaluations. Even though you're not possibly going to operate on them until 3 months, when they're neonate, you want to check their weight, you want to make sure they're feeding correctly, you want to get them involved with speech therapy if they need any nasal emboldening or any pre-surgical appliances that needs to be fitted. And then patients are going to undergo, usually have primary rhinoplasty and tubes placed at 3 months with this cleft lip repair, but they also will need revision rhinoplasty. And so it's good to just discuss that with the parents so they don't think that it's just a one-time thing that's going to get repaired, that they know that there's a series of surgeries and evaluations that their child will probably undergo. All right, so, did you guys get your handouts? Okay. I'm trying to memorize all this too much to make it too interactive, but what I wanted to give you guys was just a handout of this cartoon and the next cartoon, just for you want to make any notes. So this is usually the reference point. So the most common repair for unilateral cleft lip these days is the Millard rotation. There's actually documentation that the first cleft lip was repaired in 390 BC in China by an 18-year-old soldier. And apparently it says after he got his lip repaired, he went on to get married and have much success in the army. But some of the older reports of cleft lip repair involve scarring the two edges of the cleft and then suturing the edges together with wax, and then reinforcing that repair with a figure-8 suture. That then evolved in the 1800s and early 1900s to having a triangular flap repair, and then Dr. Millard developed a revolutionary repair of the rotation advancement technique, and it was kind of called a cut as you go technique. I'll kind of explain that. So basically, we can start with number 1. So these are the points that you'll want to mark on the patient before doing your Millard rotation. So number 1 is the lowest point of Cupid's bow. Number 2 is the highest point of Cupid's bow on the non-cleft side. Number 3 is the medial side of the highest peak of Cupid's bow on the cleft side. And I'm just going to jump over to number 8, because number 8 is the lateral side of the highest point of Cupid's bow on the cleft side. So you can kind of imagine that if 3 and 8 could come together, you'd actually have a normal Cupid's bow with this peak and this peak being the same. You could get 3 over to 8. Number 4 is the alar base on the non-cleft side. Number 5 is the columellar base on the non-cleft side. Number 9, that's going to be the superior extent of your advancement flap. Number 10 is the alar base on the plus side. 11 and 12 are kind of extra points, and that's for when you're making your cut to release the alar from the upper lip. Sometimes you need to extend that up to 11 and 12 to the alar facial groove to get enough slack to do your advancement. And 6 and 7 just mark the oral commissure. Now X is really the revolutionary design, and the reason why people call the Millard technique a cut as you go technique, because X is your back cut. And so that's sort of the variable length that you can cut to be able to rotate the non-cleft side down. So your rotation is going to be the non-cleft side rotating down, and your advancement is the cleft side advancing over. So again, just the points if people wanted to break them down in a little handout. And of course, there's some mathematical guidelines to help you. Sometimes it's hard to see, especially points 3 and 8. I think 8 is probably the hardest point to establish because you're trying to establish the peak of Cupid's bow on the cleft side. Sometimes it's hard to see that. So to give you some guidelines, obviously points 1 to 2 should equal 1 to 3 because those are going to be the peaks of the Cupid's bow, which is going to make the filter column. You want that to be symmetric, or else it will draw attention to the lip. That should be about 2 to 4 millimeters. And then 2 to 6, which is basically the horizontal width of the lip, should equal 8 to 7. Because again, that's Cupid's bow to oral commissure, cleft side, non-cleft side. And then to establish vertical height of the lip, you should have 2 to 4 should be the same length as 8 to 10. That should be about 9 to 11 millimeters. And then for the rotation flap, 3 to 5 plus X, and that's the amount that you have to back cut to get your non-cleft side to rotate down, should equal the length of 8 to 9. And that's going to be what's called the L flap when you make your incision to get your cleft side to advance over. So these are just so where people make their incisions. This is called the L flap. Never heard anyone call this the M flap, but I have heard the C flap. And basically, this is the incision that goes along the margin of the flap. It can be extended into the nostril to make an alotomy, and that's to repair the nasal floor. And also, if you're doing primary rhinoplasty at the side, you can make a marginal incision to free up the lower lateral cartilage and make and equalize it. You can see here, this is the cut to separate the ala from the lip, and also they have it extending into the alofacial groove. The C flap is usually extra tissue that you can then rotate down to fill into the defect that's going to be made once you rotate the non-cleft side down to meet the advancement flap. Some people, usually this flap is more tissue than you need to fill that deficit. So you can take some of that tissue and rotate it in to the nose to close the floor of the nose. And this again is your back cut. This schematic is just showing how you want to close. So obviously you want to close the mucosa first, and there's a lot more dissection than just making the flaps, but you have to make incisions in the gingival labial sulcus to be able to advance the mucosa over. You'll close the mucosa with dissolvable suture. You then want to close the lip, the vestibular, and that's usually with a longer lasting dissolvable suture like PDS. And at the same time, you're closing the nasal floor. You're bringing the cleft ala medial, so it has more of a rounded shape. And then you close the lip. And the lip closure can vary. Some people like to do a subcuticular monocryl. Some people do proline. Some people do horizontal mattress sutures. Most people who do subcuticular suture will then put Dermabond over the lip. Alright, so I had a video of Dr. Millard. So you can order a Smile Train DVD if you're at all interested. I recommend it. It has 2 volumes. Volume 1 goes over primary cleft lip and palate, and volume 2 goes over secondary. And actually there's it has these little animations, and you can hear the speakers describe the complete animation on how to do the repair, where to make your cuts. They also show intraoperative video of people doing the procedure, so it's really helpful. But I don't know, if I switch it over to Windows, will it, should I try it?
Yeah, just push the button.
Right, so we'll just look at Millard's unilateral care.
To recap Millard's rotation advancement procedure in its appropriate chronological sequence, the C-flap is elevated and the medial lip element rotated down. A marginal incision is made, allowing dissection of the lower lateral crus on the cleft side and repositioning. This is sutured in place. The C-flap is trimmed if needed and is sutured to the non-cleft side of the defect from the medial rotation segment. The lateral lip element is prepared with dissection away from the muscle pennant and a gingival-buccal sulcus incision, allowing the lateral lip element nail or base to move into more normal position. The mucosa is sutured on the inner aspect of the lip. The muscle pennant under the alar base and from the lateral lip element is sewn into the downward rotation defect as shown here. Millard's lateral advancement flap is then sutured into the defect from the downward rotation medially. Any excess skin at the marginal incision is resected and the nose carefully closed.
Well, I'm glad that worked. Cool. So yeah, if you're interested, you can get the DVD for free. I think I actually ordered 3. There should be 1 in the residence room. Okay. Thank you, Dr. Millard. So the following is our intraoperative photos from Dr. Wong at OHSU, just to really hammer it in. So here's a baby boy with a right-sided unilateral cleft lip. And you can see from the view from below, he also has a cleft of the alveolus and of the palate. So he has his intraoperative markings. Again, you can see this is the cleft side. So this would be 0.8, which would be the cupid's bow peak on the cleft side. This would be 0.3, which would be the medial aspect of cupid's bow for the cleft side. This is 0.1. Which is the lowest point of Cupid's bow. This is 0.2, which is Cupid's bow peak on the non-cleft side. He has the polymolar base also marked. This is 0.9, which is going to be the superior extent of his advancement flap. He has the alar base on the cleft side marked, and then he also has points 11 and 12, which again is the alar facial groove, where you can make your cut if you need to get more of an advancement. Then marks his flaps, so this would be the C flap, this is going to be the L flap, this is the M flap. And I think here what he's marking is just where he wants his philtrum to be on the non-cleft side. Another view of that. So here the mucosa has been closed, the muscle has been closed. This is the C flap again, which will be rotated down to close this defect. Here. And it looks like he closes with horizontal mattress sutures, and it looks kind of like Bilateral, but I can't tell if that's supposed to be a dissolvable suture. So I'm for cleft palate repair. So for cleft palate, there's a lot of different techniques that you can use, and people like to look at the defect and decide what procedure instead of just having a favorite procedure to use. So for this cleft palate, I can see it's for orientation, the tongue is here, the patient has a demon retractor, and it looks like the primary palate is not have a cleft. This is just a cleft of the secondary palate. So here, it looks like he used the von Lingenbeck palatoplasty, and that's actually a little bit easier than the more common furlough double opposing Z-plasty, which are used for palatoplasty. The furlough has an advantage of being able to also lengthen the palate, whereas with the von Lingenbeck, you are elevating, you make an incision here, in the mucosal line, the hard palate, and then you also are going to make an incision here along the cleft margin on each side. You're going to elevate up mucosa, muscle, and then you have the nasal mucosa, and then you basically just repair everything in the midline. So you can see that you first started with closing up the bifid uvula and making one uvula, and then now he's closed muscle and mucosa. So from what I can see, if you see someone that has a midline suture line in their palate, and that's usually a von Langenbach repair. But if they have something that looks any kind of diagonal to it, it doesn't look like a nice crisp C, that's usually a furlough, and that they have the double closing glasses. Alright, so the last thing I wanted to talk about was just humanitarian missions. This is from the Smile Training website. They say, why clefts? Why focus on cleft palate and cleft lips for humanitarian missions? And their point of view is that clefts are a significant problem affecting millions of very poor children. The cure has already been found. The impact of the cleft surgery is dramatic, immediate, and permanent, and that this is one of the best low-cost, high-impact interventions in the world, and they call it a modern-day medical miracle. And once the cleft is repaired, it never comes back.
Can I ask you a question about millions? So there are 4,200 new per year.
In the U.S.
I understand. In a population base of 230 or 40 million. And there's around the world 3 billion or so. I'm just trying to wonder how you get up to millions.
So
I mean, I can see getting up to tens or hundreds of thousands, maybe even a few 100,000, but hard to imagine millions.
Well, in very poor developing countries, they are repairing clefts in kids who are 18. They're repairing them in adults.
Yeah.
So it's not just the
Incidents.
700 each year. It's
The
really,
prevalence.
yeah.
Probably still doesn't come to millions.
Yeah, but it sounds good
Well,
for
this is what
fundraising.
got
The only other thing, I mean, the only other comment I'd make about that is you yourself showed the plan for cleft kids.
That's what I was going to say.
Oh, okay, sorry, go ahead. It's more than just a
That's in
single
my,
operation.
That's in my shortcomings. But yeah, exactly. What Dr. Most is referring to is that they market the cleft surgery as just a one-time modern-day miracle and then you're done. But we've already seen in my previous slide with Mount Sinai that it's not just a one-time surgery. That the kids need speech therapy, they need orthodontics, they need revision surgery. And so who's covering that? Is Smile Train keeping track of all the kids and coming back and doing their revision rhinoplasty? Or are they just repairing the lip sort of for cosmesis and saying that they can get back into society without being ostracized? And there's also some other shortcomings we'll talk about. All right, so this is my own thoughts on humanitarian missions. There's a lot of different models for the humanitarian mission or the cleft teams that travel abroad. I like to divide it into independent versus corporate, and by that I mean independent is like the trip that I went on where it was 3 surgeons. Each surgeon brought their sutures, they brought donated supplies from the hospitals where they worked. We worked with a local hospital where we used their operating rooms, most of their surgical equipment, their anesthesia machines. So from some of the papers I read, these independent trips usually have a budget of about $10,000. Whereas the corporate model, that would be Smile Train, Operation Smile, they usually send a team of 33 people. They'll send one team ahead of the surgical team to evaluate all the children, do the pre-op, check their weight, get labs, and then make the OR schedule. And then when the surgeons get there, they operate, in the independent model, most people do about 15 surgeries a day. In the Smile Train, they will do 250 surgeries in that week. And then they have a third team that's there for the post-operative visit. So the third team stays there for the week after, making sure that all the kids are okay. They also will do educational seminars for anyone in the area who wants to learn how to do palate repair, who obviously train. And they do a lot of the surgery videos. They also have a simulator that you can download. It's only on PCs, but it's really cool too. It's like quizzes you on where to put the incisions and everything. The other model is whether or not you should be bringing surgeons from the United States, Australia, Europe to the developing countries, or should you bring surgeons from the country to the United States to learn how to do clefts and then send them back to train other people. If you follow that model, then some people say, well, you can still fundraise and collect supplies and instruments and money here, and then you can send that to that country so they can still offer free cleft surgery. Because some of the criticism of that model is that the poorest kids still won't get surgery because they don't have money to go to the doctor. And then the other thing is just fundraising versus physician fund. Usually in the corporate model, you can go online to Smile Trade, you can donate your $200, they'll send you a picture of a kid who got their cleft lip repaired. Or you have a lot of the independent physicians who have their own little budget. They may do a local fundraiser in their community, but usually their hospital will donate, sutures and stuff like that. They'll bring their own surgical instruments from the hospital down to Guatemala or Peru, and then they're working with a much smaller budget. So this is a Smile Trade website again. They say for just as little as $250 and a simple 45-minute procedure, and they have a report card. So Smile Train was started in 1999. They are trying to hit 1 million smiles. They're at over 800,000 so far. And just to highlight a couple, so they estimate that they will do 120,000 plus free cleft surgeries this year. They then are located in 87 countries. They have 2,300 plus Smile Train partner surgeons. So you can go online and become a surgeon with Smile Train and either train physicians in developing countries who can come over here and train with you, or you can go over there and do surgeries. Interestingly, they only have 60 staff members. So they really are using the majority of their money to be put into the Cleft program instead of paying salaries. Let's see here. They've had over 2.3 million donors. And the other thing about Smile Train, in addition to the video, they try to find every article on related to cleft, lip, palate, speech therapy, whatever the kids need, and they make all those articles free to anybody. So Operation Smile is the second largest cleft, lip, and palate organization. They were started in 1982. However, they've done only 200,000 surgeries, and they've been in business longer than Smile Train. Their model is to send basically a fleet of medical volunteers. If you go to their website, they have 2-week trips for the entire year. You can sign up for those 2 weeks to go and volunteer. They're starting to do more training and support of local surgeons, so getting the local surgeons in the community to come and work with the volunteers that come over. I put this in here because I applied for their vegan fellowship, but was rejected because I'm an ENT resident. So both Operation Smile and Smile Train are plastic surgery run. And it's interesting because they don't talk about putting in ear tubes for the kids or any of the otologic complications of cleft and palate that we deal with. And they also won't accept ENT residents.
What do you think about that, Melinda? What do you think about them not wanting to train people who have skills to help other people?
That's why Ralph Millard was at the University of Miami.
No, I'm asking Melinda what you think.
No, I mean, I think that I think the whole evolution of cleft, lip, and palate being under the domain of plastic surgery is pretty interesting, considering that we deal mostly with the mouth and we deal with the complications of cleft palate that result in
What argument do you think a plastic surgeon makes in saying they shouldn't train us in how to do this? They really want to help people, right?
I don't know. I mean, there really isn't. I mean, I know that this is like the last dominion they're trying to have, and everyone is taking pieces of plastic surgery, with ortho doing hand also, and all these other arguments I've heard. So they want to hold on to craniofacial.
Yeah, it's very political. There are very few places you're going to be fortunate enough to go to a good place where otolaryngologists do this. There are a few other places. It's been a big roadblock. I think one. I can't read other people's thoughts. I never went down this road because I didn't want to get into the politics of this myself. But I mean, if otolaryngology folks, really the people that make most sense to do this are pediatric otolaryngologists or facial plastic surgeons, one of the two, because we can deal with the voice stuff, the VPI, the ears, and the whole bit. it does take a whole team of physicians and nurses and so on to take care of these patients. And it's unfortunate, I think, that the politics are getting in the way of getting people trained to do the right thing. And there are a limited number of cases, 4,200 cases per year in the United States. So if they lose that, if it gets diffused, then they're going to lose a lot. So I think that's part of it. But anyway,
Yeah.
we digress.
Who doesn't hear? There's one fellow who doesn't hear, but did a lot.
Lorenz does.
Yeah.
He's a nice guy. I mean, I never asked him.
He never-
Little by little,
stuff,
we've
but
had a significant increase in the number of pallets Anna's been doing, and
furloughs and things.
yeah,
Yeah.
and the lips are exclusively in the realm of the plastic surgeons here. That's not the case in several of the major children's ENT centers. Little Rock, Arkansas, for example, is almost exclusively otolaryngology doing left lip and palate. Same thing with up at Davis with Greg Senders, and there's a handful, but it's modest at best, and it's been a hard fight in each place, usually as a consequence of poor, just not strong plastic surgery programs.
Yeah, Colorado, the ENT residents do all the cleft lip palate because they don't have the plastic surgery residency. They do it with the
With the
plastic surgeons.
When
One of-
Millard was doing this, he would, to be politically correct, would invite the otolaryngology residents to watch. And then he would do just what Joe Goldman used to do at Mount Sinai. He'd put his hand over the field while he was doing the actual work. That's how guarded he was to protect his.
I'm trying to understand this. Is a one-handed surgeon?
He was a very good one. He would have his fellow
Actually-
or resident doing the work, and he would make sure that you couldn't see what he was doing.
The same, you know,
It's a good time to pick his pocket.
at the University of Washington, we had an elective period, and I wanted to spend time with Joe Gruss doing this stuff. Kathy C. had made a lot of inroads in doing pallets there, but you know, she was friends with him. I asked him, I was going to be allowed to watch but not scrub those cases. This is back in the late 90s. So that still exists to a certain extent. Of course, later on they asked if we could train their residents on how to do microvascular surgery at the neck.
Yeah.
And we said
Yeah.
they could watch.
Oh, yeah.
Yeah, there's a ton of well, not a ton, but people who are trained in cleft lip and palate surgery who are otolaryngologists have had a lot of fights. And Patrick Byrne at Hopkins, he actually started a competitive program across the street, like at Hopkins equivalent of camp. He went there, he's a Hopkins physician, but he went there to establish his cleft lip and palate program because the plastic surgeons or the politics behind it wouldn't allow him to get privileges at Hopkins. I put this paper up just to briefly touch upon the fact that there's not much data on the effectiveness or the safety profile of doing humanitarian missions. This paper is from 2009 and was basically written with the help of Operation Smile. I think William McGee is their chief medical officer. Basically, they developed or started using an electronic medical record in 2005, so they were able to keep track of complications and outcomes for their surgeries abroad. And so this paper was written up, and it basically showed that the complication rates were similar to what's seen in the United States, and that it was safe to do the surgeries abroad. So just in the last few minutes, I'll just buzz through my own experience. I've been on 2 humanitarian missions so far. The first one I went on was in 2010 to Peru. I just went on a general medicine and dental care trip. Actually, the dentist used me a lot to do all their abueloplasty because they had sutured it a long time. So they pull all the teeth and then used me to close it. But anyways, we saw approximately 60 to 70 patients. I saw approximately 60 to 70 patients per day. We worked about 13 hours. And the most common diagnosis that we diagnosed was worms. So
Where?
where? The digestive tract. So
The surgeon came
not
over.
the foot.
All the time.
You guys came over.
Sinai.
Noses.
No, I came home and took albendazole and
Oh, boy.
everything.
Oh, boy.
Anyways, patients, this was our clinic, as you can see. The clinic, this is a tarp that we brought that's providing shade, but it's just bare concrete. And then the people there built this little brick small room, and that's where all the OBGYN exams took place, with a wooden plank as the table, and Steve Belton was the OBGYN who did all of those exams. These are two nurse practitioners who came. And then my second trip, I went to Mazatenango, Guatemala. This was in 2011. There were 4 surgeons, 3 ENTs and 1 plastic surgeon, and actually the plastic surgeon who came down is a Operation Smile partner. But he was at the academic center. I think he may have been at Ohio State, and he left for private practice. Other plastic people at Ohio State were really upset about that, so they stopped letting him do clefts, pretty much. They kind of just walked him off. And so he joined up with us to do clefts abroad. And so what we basically did was we got there early Monday morning. We went straight to the clinic. There were 70 people waiting for us. We saw 70 people, 3 of us, in a morning, well, basically a day. And then around 6 p.m. we started operating. And what they do is they do cosmetic cases the first night, and those cosmetic cases then go into a fund to pay for the cleft palate surgery. So we did 2 rhinoplasties and upper blepharoplasty that night. We finished around midnight. And then the next day, we saw kids again all throughout the day and operated again at night. So that night, we did the first cleft repairs, and we did them on open surgery. Our anesthesiologist, so in Santiago, that was really insane. We had a little nickname for everybody. But anyways, he was basically our equivalent of like a nurse anesthetist. So he was comfortable doing adults. We then brought a nurse anesthetist from Dallas who basically did the children anesthesia. This is kind of our little setup. You see no scrubs, just sterile bloods. I'm using my standard REI headlight. One of those battery operated ones. And these are all supplies and supers that we brought down from the States. And then here you can see just drying out our Millard rotation. And interestingly, they actually advertised. So we worked out of Hospital Shalom. They did commercials on the local TV. They had flyers. The local missionaries were informed so that they could go out into the rural villages and bring the children with the cleft and the Palate. And of our local team, we had 1 general surgeon who did all the post-op care for the patients, and 1 pediatrician who did all of the pre-op clearance. This is an example of our OR schedules. And so you can see that the kids have their name, the procedure. This is my handwriting, so that's all good write in Spanish, and their age. And then here we had to weigh them, and that was written to the side. So there were a couple little babies that were canceled because the nurse anesthetist didn't feel comfortable putting them to sleep. But we did about 15 cases per day.
Do you know how a hospital in Guatemala became known as Shalom?
No, I don't know. I don't know, but
Bet you I know.
That is really medical mission.
I don't know, but I do know that the group that I went with,
It's a lost tribe.
the guy, Dr. Straightman, who's out of Los Angeles, he used to be at UCLA. He's been going there twice a year for 20 years. And he actually has expanded the hospital with funds that he's raised through his foundation. So he added the basement operating room, with basically is 1 large room with 3 beds. They have 2 anesthesia machines and 1 bed in the middle that's all facing under local. He added a kitchen because he saw that a lot of the kids that were coming in were malnourished and their families didn't have money to buy food, so he added a kitchen to the hospital so that we could go get food there. I don't know if it was kosher. We actually had a laundry installed and all of these things. So, a lot of stuff. So here's my take on the shortcomings of mission trips. They're missing out on the whole multidisciplinary team. They're missing on having the nutritionist, speech therapy, orthodontics. And the biggest thing I saw was ears. I mean, the kids are getting their lips repaired and their palates repaired, but no one's putting in ear tubes. They still can't hear very well. They're not doing well in school. I guess the stigma of having a cleft is taken care of. But we do know that 96% of cleft palate patients require tubes, and 50% require multiple. So we are kind of doing them a disservice by not putting in tubes for them. And then the other criticism is sort of the lacking continuity of care. The group that I went down, they go every August, every February, but they're basically trying to track down kids, calling the local missionary, have you seen this little kid, can you bring him in? You know, they're 3 days away walking, and so we go drive out there, pick them up, or we make little trips to the village to see all the kids that we operated on 6 months ago. But it would be nice to have maybe a partnership with other independent physicians who want to go down, and so that there's always someone down there taking care of the kids. The other criticism that short-term mission trips is the idea of operating and then leaving. You don't know if the kids are still doing well. You just, you're gone and there's no one to take care of them. And then the idea of, you give a fish to someone that feeds them for a day versus teaching them to fish, and that's to save them a lifetime. So should we be doing more things with identifying surgeons in the developing countries who want to learn the technique and then paying to bring them here for 6 months or a year to do basically a fellowship. And then again, is it really a problem solved by $240? My references, just want to thank Dr. Torello, who's a former fellow at OHSU, and Dr. Wong for their help with slides, and photographs, and just ideas. Any questions?